Hello, everyone. Welcome to the 2020 conference on metastatic breast cancer. Thank you for joining us for this live session of Treating Brain Mets. My name is Christina Reese, and I am your moderator for today. And this is my first time, so y'all be nice to me. I am a little nervous. Actually, I'm a whole lot of nervous. But I am excited to be here, like you, learning and having as much knowledge about metastatic breast cancer is important. I was diagnosed in 2017 with stage 4 metastatic breast cancer. And of course, metastatic breast cancer is when the cancer moves outside of your breast to other organs in your body. So in 2017, like I said, I was diagnosed at the age of 39. I was told that the cancer has spread to my brain, actually spread to my skull all the way down to my femur on both sides of my body. And in December, I was told that the cancer had actually spread to my brain. I just completed whole brain radiation, which was a difficult thing for me, but I was able to get through the process. So that's why it's important to me. And at this time, we are going to actually turn it over to Dr. Tsien. Did I say it right this time?
You were awesome. Thanks for that introduction. I really appreciate it very, very much. So it's really my pleasure to be with you today. And my topic is to talk about breast cancer brain mets. And so the first thing that I'm going to talk about is just what the current management and certain things that are in the landscape, things that we're excited about in the treatment of breast cancer brain metastases. So I'm going to start and just talk about in terms of brain metastases, because we're using MRI and CT scans, there is an increased number of women that are diagnosed with brain mets. And you can see that breast accounts for about 15% of patients that have brain metastases. And so about 10% of women with metastatic breast cancer will have brain metastases at presentation. And up to 50% of women with HER2 positive breast cancer will develop brain mets during their course of treatment. And this can occur really at any time, sometimes even many years after their diagnosis. So what are some of the signs and symptoms of brain metastases? So the most common one is headaches, but other patients can present with things like seizures or weakness or issues of confusion or balance issues. So these are many of the potential signs and symptoms of brain metastases that may trigger us to obtain imaging. So one of the things that I wanted to really focus on is that there are many aspects that are very important in breast cancer brain mets. And this is neuroimaging, that our radiologists are very important. So they're important in choosing the right treatment for the right patient. So sometimes these lesions spread from the breast, as Nani just described, and treatment can be focal, like radiosurgery. But sometimes these breast cancer cells can travel to the spinal fluid. And in those cases, when they're surrounding the lining of the brain or spinal canal, they may need treatment like whole brain radiation therapy that was just discussed. So in some cases, our neurosurgeons are very important as well. When should we consider referring to neurosurgery? And there are several indications, including obtaining tissue. So being able to confirm that this is due to the breast cancer. Because sometimes patients that present with a single lesion may not be due to brain mets. It may be due to other things. The second is patients that develop symptoms. If patients develop an urgent symptom and that there is kind of swelling in the brain, then surgery may be very important. And the third is really if there's a single lesion, then patients who develop surgery and who have a controlled primary may actually have a benefit. So it really is a kind of a group, not just kind of a radiation, but really a whole team that's really involved. And so this slide just shows that not all brain mets are created equal. and that this is what we call a graded prognostic index, or a GPA, just kind of like in school, where that the different kinds of cancers have different prognostic factors. So for example, patients with breast cancer likely need to be treated on a separate clinical trial than those with, for example, with lung cancer. And that specifically that the subtype, the type of breast cancer, can also impact the type of treatment needed. And so here we can see that there is really quite a difference in outcome in patients with brain mets. So even though this is kind of the median, or what, 50% of the patients, about a third of the patients present actually in the best group. They present in the group that has an outcome almost ranging up to 25 months. And so this really tells us that patients on breast cancer brain mets, they need to be on different trials, that the subtype, those that are HER2 positive, should be in a different clinical trial because they may have a different outcome than the other groups. So I'd like to just focus as a radiation oncologist on what's the role, what specifically about radiation is currently being used. So I wanted to start by talking about a case. So this is a woman that had HER2 positive breast cancer that was metastatic, that spread to the liver and bones, and she was on HER2 therapy with Herceptin. But she presented with headaches and left arm weakness, and she had an MRI scan that showed quite a large 4-centimeter lesion that was involving almost into the ventricle. And so the surgeon actually removed that lesion, and the patient was on a clinical trial. And because of the spread, the patient received whole brain radiation along with a HER2 drug called lapatinib. And the patient was followed. The patient had a follow-up scan, and it showed that one of these areas actually got bigger on the MRI scan. And so they had scans that were done to see what that was. And because of the high perfusion, this was consistent with progression, that this was a progression in a single brain met. So the patient went on to receive a single treatment, so a single day treatment, what we call radiosurgery, to that area, and has been disease-free actually for about 3 years after this. And so this is one of the things that I wanted to highlight, is that when patients have limited, so kind of a small number of brain mets, there are several landmark studies that were comparing what we call focal treatment with radiosurgery and whole brain. And the objective in this study was actually cognitive function. So they were looking at specific neurocognitive tests, so testing patients' memory and recall at 3 months. And so on this study, what it showed was that patients that did not receive whole brain had no difference in overall survival. They had a very similar outcome. And so what I'd like to showcase is that when we give focal treatment, those patients need to be followed very, very closely with follow-up scans. Because compared to patients who receive whole brain, they will require additional therapy. So there are new lesions that come that require treatment, and that can be with radiosurgery or with whole brain radiation or with surgery. And so this is kind of some of I'll say the pros and cons to focal treatment. But this is the benefit. So when we compare focal treatment, so just radiosurgery, like the picture that I showed, compared to those who received whole brain, especially at 3 months, but even at 6 months, there was some benefit in terms of their recall or their memory. And so what does this tell us overall? It tells us that in terms of potentially patients with very focal, with a small number of lesions, that treatment with radiosurgery can improve cognitive function and quality of life, but they need to be very carefully followed. They need MRI scans in order for us to make sure that the survival is the same. So basically, it's really important that we select patients for the right treatment, and that patients may have in order to control the disease in the brain is probably the most important factor. And there are many ways now with medical treatments that Dr. Zimmer is going to talk about, as well as whole brain radiation and focal treatment that can really improve patients, not only their quality of life, but also their outcome. So that's really my kind of take-home message. So I do want to talk about another case. So this is another young woman. So she was 36, and she had ER-positive breast cancer. And she was treated actually because she had disease in both breasts. She had bilateral mastectomies. So she had both breasts removed, and she was treated on hormone therapy, on tamoxifen. But actually she didn't tolerate it very well, so she stopped her treatment, and she was followed closely by her medical oncologist. And what happened was, kind of 8 years later, she presented to her family physician, and she had a month history of headaches. And she was having more headaches, especially in the morning, also with some nausea. And she had more difficulty actually writing, just kind of very subtly, just kind of a subtle difference. And when her physician got a scan, she was found to have a tumor in the right cerebellum. And that actually was it was completely removed. So this is kind of the pre-op, and then kind of post-op, we just see the cavity. And so it was breast cancer. It was the same breast cancer that she presented 8 years earlier. So it was hormone positive. And so now that she had this lesion, the question was, what treatment should she receive? And so she actually received just focal radiation just to the resection bed. And so there actually is a study that showed comparing focal treatment just to that surgical bed, or radiosurgery and actually whole brain. So it was really whether we should treat the entire brain or whether we could just treat that surgical bed. And the outcome actually was to look at survival as well as cognitive function. So it was looking at both aspects. And what it showed is that those patients that had whole brain radiation had better kind of control, especially at 12 months. So the further out the patient, because many of these patients now will have very effective systemic therapy. And so that local control is very important. And so it is, the survival was also exactly the same, so on both groups. And so this is one of the things that very similar to the other study, to the multiple studies that have done, is that patients with cognitive function, patients that were treated with focal radiation at 6 months had a better kind of cognitive function than those who received whole brain radiation. And so what we're showing is that nowadays there are multiple different types of treatment for brain metastases, and that the survival is very similar, and that whole brain radiation can improve control, but it does have perhaps some kind of long-term perhaps side effects or quality of life. And so the question is preserving cognitive function. So kind of replacing whole brain with perhaps systemic therapies might help us to not only provide local control, but also prevent additional lesions from recurring. And so we are hopeful that with new therapies, that new potential systemic therapies that cross the blood-brain barrier, that potentially we can use those kinds of treatments to hope to replace whole brain radiation in the future. So one of the things that I wanted to talk about is just the ways that radiation has improved. So with modern radiation, there are many, many new tools to give radiation to the brain that are very, very precise, that can really help avoid treating the normal brain. So these kinds of treatments are in the past used with a frame to really get that precision, especially in a very critical spot like the brainstem. But that nowadays we actually have masks, so very non-invasive ways. So ways where we can repeat the treatment multiple times. We can do radiation to different areas as needed that just require placing a mask that can be done even just in one day or just a few days. And so the reason why these treatments can be so precise, similar to a frame, is that they do have a what we call a very special mask, but also a very special neck immobilization, very special ways for us to image and to actually monitor during treatment that gives us the same precision as having a frame. So this is a picture showing the machine with actually an arm that takes a CAT scan. So right before treatment, we actually obtain a CAT scan to optimize to brain so that we can be so precise that we can match the patient to the image. So that this allows us to automatically change that radiation plan right to where the patient is. And so these ways allow us to give that high dose of radiation, almost kind of like surgery, very ablative doses in a very few number of treatments. And so one of the things that I want to highlight is that as we talked about our radiation oncologists and our surgeons, but our imagers are also very important because nowadays we're giving a lot of new therapies. So things like immunotherapy or HER2 therapies like TDM1 that can cause a reaction. So many times, this is a picture of someone that received a focal treatment, just like that picture with radiosurgery. And this is 2 years following the radiosurgery. And this patient actually was operated, and it was what we call radiation necrosis or imaging change. So this was not tumor. This was not the tumor coming back. This was just a reaction from the long-term effect of the radiation. So having the right diagnosis is very, very important in determining what's the right therapy. And there are lots of new therapies that we're using in our clinic with our neurosurgeons. And so this is a picture of what we call kind of a laser ablation or lit therapy. So again, this is done almost as a one day. It's done with a very, very tiny incision, just a few millimeters. And this allows us to actually be able to get a diagnosis and treatment really in a relatively less invasive way. So this is a picture of kind of all that swelling that can occur post radiation. So this is kind of 2 weeks post the procedure. This is 2 months, and this is kind of 6 months, and this is a year. So that these types of treatments can not only confirm that it's just a radiation effect, but actually by treating even just a part of that tumor, it can actually help to resolve that. So this is kind of a new tool that's really helped us to kind of manage patients with brain mets. So in summary, I really want to kind of focus that brain mets requires a multidisciplinary treatment approach. It requires our medical and neuro-oncologists working very closely with our radiation oncologists and our neurosurgeons and our neuroimagers, neuroradiology. So many times we're presenting this in tumor board, reviewing the scan, and every time you're having kind of a whole team to really follow your scans to help us kind of choose the right therapy. And so it really is something that is much more kind of, there's so many more options and tools than before. And so it really requires a kind of a selection personalized to the patient, that whether we do surgery or radiosurgery or whole brain really is a very tight balance between having the best local control, but also focusing on outcomes in terms of side effects and quality of life. So it is a very, very kind of careful balance where in each individual we're making the right decision. And that many times there can be treatment-related imaging changes and late radiation necrosis that can mimic tumor progression. So, and that's an important keyword, mimic. And so being able to distinguish between the two is really key. So in the next few minutes, I'm just going to kind of very, very briefly just present some ideas of kind of new treatments or new things that are occurring. So one of this is really patients who are getting whole brain radiation. So there are a study that was recently published that looked at patients who got whole brain radiation with a neuroprotector called memantine, and a new way of giving whole brain radiation, what we call hippocampal avoidance. So basically this is using very conformal ways of giving the whole brain that can spare these very important areas called the hippocampus. And so this hippocampus are these neural stem cells that are very important in memory. And so we can develop ways to preserve or to reduce the radiation to these hippocampal regions. So this was a study of over 500 women, 500 patients, mainly lung cancer, that looked at hippocampal sparing whole brain. And so it was mostly lung cancer with some breast cancer patients. And these patients had a very good prognosis, a very good performance status. And it showed that starting at 3 months, there were patients that received hippocampal sparing had a better cognitive function. And so again, there are very few patients at 12 months, but certainly there was patients who are living at least 4 months may benefit from this new treatment. And so basically, again, I just want to share that radiation-induced cognitive impairment is really a complex problem. And it can affect areas, not just the hippocampus, but also what we call the prefrontal cortex, or areas of higher cognitive function. And cognitive impairment can be due to many things, not just radiation. It can be due to surgery. It can be due to chemo brain. It can be due to seizure medications or other things. But for patients that require whole brain because they have multiple brain mets, 10 or more, or who have leptomeningeal, patients with good performance status and controlled disease with a survival of greater than 4 months, that hippocampal sparing has now been something that can be used in the clinic now. And so one of the things that Dr. Zimmer is going to talk about is really systemic therapy. And for us, this is a real importance of developing strategies that prevent brain mets altogether. And in order for us to kind of target these silent infiltrating cells before they even occur, and that this kind of molecular crosstalk between tumor cells and their surrounding microenvironment are really going to be very important. And so this is where radiation combined with therapies are really key. So I'll just give you a couple of examples. So these are targeted treatments, for example, this one in lung cancer, where the combination of radiosurgery plus drug actually had an improvement in survival. And again, those kinds of concepts are things that need to be tested in randomized studies. This is another one looking at radiosurgery or focal treatment, where I'll give you this idea of taking a cold tumor and converting it to a hot tumor. So radiosurgery can help prime responses to immunotherapy so that the combination can have a better outcome. And because the combination of treating with radiosurgery and immunotherapy may have a better outcome because the radiation has an impact on the microenvironment, and that if we can combine them early, they'll have a better chance of working. And the last concept that I want to just show is this new drug, what we call tucatinib. So again, the idea that these drugs that are small molecules, that are very specific to HER2 that were just published, that can cross the blood-brain barrier. So drugs that can not only impact the CNS, but also systemic therapy. So that's what we need. We need drugs that are active in brain mets, not only in the brain metastases, but also in the systemic disease. So this is one of the first drugs that have shown this activity in the brain, and that we hope that by kind of combining with radiosurgery, that we can show an idea of kind of replacement of whole brain, that we can prevent distant brain mets. So I think there are many lessons that we have learned, and we want to be able to, in the future, exploit, I'll say, novel interactions of radiation and systemic therapies, that we can really improve outcome by having them work together. And so again, I think that this is the area that I think that I'm very excited about, is that these systemic therapies are now evolving rapidly, and Dr. Zimmer is going to talk about them, but that there are novel ways that we can combine them with radiation that may help improve outcome, but also focus on the toxicity or the quality of life, really help to prevent any of the cognitive decline that might be associated with some of our therapies. So the importance is really that the best palliation will have the least impact on the patient, and to maximize the probability of local control, but on endpoints that are very important to the patient. And I think that's really where our focus is. It's on our patients and how we can improve their goals. And so I'll leave this, and I'm very excited about answering questions at the end. So I will stop sharing my screen, and I'll send it back to Nani.
Okay, thank you so much for that. We're going to turn it over now to Dr. Zimmer.
Hello, everybody. I'm Alex Zimmer. I'm very happy to be here with you guys and discuss the systemic therapy for breast cancer brain metastases. And let me see if I can share my screen with you guys. So let me know if this is working or not, if someone wants to sign it to me, but just to, okay, so it seems it's working. So we're going to talk a little bit about the systemic treatment and then a little bit about prevention. And I'm going to explain what I mean with that of brain metastases. And I was told to talk about more like the updates on research. There are some things that we need to establish on the background, and I think there's a lot of misconceptions and questions about that. So I did it very, very briefly with some points here, and I hope that I can, you know, through your questions, we can discuss much more than that, because I hear from the patients there, and we've been looking into the questions that usually people have, and I think that will be much more interesting than whatever I have to say to you today. But just to start, let me see, I probably have to click here. Yeah, just to give some baseline of how frequent are the breast cancer brain metastases. You can see there that we have a big number in the screen that I'm sharing with you. That is predicted of breast cancer new cases in 2020 in the USA, and we know that breast cancer is the second most common cause of brain metastases. So the first one is lung cancer, but the second most common is breast cancer. And there are several different numbers if you look at the frequency of brain metastases, and this is because it's just groups that look back on whatever data is available to try to understand how frequent or not that is. And you can see here that I put in this chart that is there. This is not like the absolute number. We have different reports on it, but just you know, whatever we found more frequently. And we see here that you know, hormone receptor positive disease, hormone receptor positive breast cancer is the most common form of breast cancer. And this is the less frequent form to have brain metastases, actually. There are numbers saying that 7.6% to 14% of these patients will develop brain metastases. I'm mentioning that because I saw some questions. People were already wondering about that. So let's go in detail here. I think it's interesting for you. Then the HER2 positive is the one that subtype of breast cancer that actually brought it all up because it started to become very frequent. It's usually used to be a very bad prognosis breast cancer, and because of the treatments that are very targeted and been evolving, the systemic treatment improved a lot, and there's so that also I think proportionated the effect that it's going more to the brain metastasis, but also the HER2 tends to have a predilection for the brain. So we see that the numbers that we are having in the most recent reports are about 25 to 55% of the patients with HER2 positive disease may present with brain metastases, and that's related to the ones that have systemic metastatic disease most commonly, but it can be the first place as well. In terms of the triple negative breast cancer, that's a more difficult group because it's been described more recently, just because that's the group that we don't have hormone receptor positive, we don't have the HER2 positivity. So it's kind of, we are still looking for better ways to treat that, but it responds to chemotherapy in some cases. And it's about 20% of all cases of breast cancer are triple negative. And these tend to present brain metastases in up to 50% as well. So this is just to have a basic idea. And I like to put this slide as a kind of a provocative way, because I like to put this big list of publications here in this side that you can see, that just to show how much we've been talking about it and for how long we've been talking about brain metastases, and how much we still have to improve the treatment of this and the data around that. So the second thing that I want to show, and there was some comment about that, what are the systemic drugs that penetrate the blood-brain barrier? Because we talk a lot about that. And this is a list that I did, and it doesn't mean, the goal is not to be super duper complete. It's just something that I looked up in the last 10 years or so, like any data of chemotherapy used in breast cancer that would report anything about brain metastasis or effect in brain metastasis cases. And to summarize this, you see it's very small letters. It's not supposed for you to read and have all the data, but just to have a general idea. What I put here is, what I found is about 18 systemic agents, the chemotherapies and treatments that we talk about all the time, that are in multiple different combinations here, or studies that were done, and they show variable responses in the brain lesions. However, one thing that we can see is that the median progression-free survival in these brain lesions was about 6 to 7 months. So it didn't improve much, except for the most recent one that we will talk about, the tucatinib situation, and I'm going to go into that. But that has to do, this picture that we see here has to do with several different things. And I want to mention something here, that what's the difficulty in the systemic treatment of brain metastases in breast cancer or in general. I'm going to talk about breast cancer specifically because it's our topic today, but the main issue we talk about a lot is about the blood-brain or blood tumor barrier penetration. Like we learned, and I'm sure you guys heard about that the brain is supposed to be a sanctuary. So the body was built in a way that to protect the function of the brain, that is the main function of our thinking and living and so on, and coordinating all the body, that there is this barrier in, so not everything that is in our blood system is coming directly to the brain and affecting it. There's a kind of a control about that, and that's the blood-brain barrier. So not every medication gets there in the same way. Now, we've been in the recent years, if you look at preclinical or the research that's been done with cells and with mice and so on, trying to understand more about the brain metastases. And I'm talking about that because I'm from NIH and I work closely with Dr. Stig in her lab. And maybe you heard about that, but we try to base our work in those things preclinically, or what's done in terms of what we find on how the brain barrier works. And we've been seeing that the blood-brain barrier is different when there is a tumor there. So much so that people are calling it blood tumor barrier. And it changes the way the drugs penetrate a little bit. So cytotoxic agents, which are the chemotherapies that we are used to hear about, a lot of them penetrates it, but not consistently, meaning not every lesion in the same, let's say you have brain metastases, there was research done showing that not every lesion receives the same amount of the drug that is there, even penetrating, but doesn't get the same level in all the lesions. Not every drug penetrates in the same level to the brain. So there's a lot of problems with that. Now, hormonal agents, we think, we know that penetrate the brain, and perhaps that's one of the reasons why the hormone receptor positive breast cancer has less incidence of brain metastases. Perhaps there's something in the type of tumor cell that is there. But anyway, anti-HER2 agents, we have some of them that penetrate partially. It seems that tucatinib penetrates better now. So there is a lot of things to consider, and I just made a list here of things that little issues that I want you to be aware of, that are as I was mentioning, there is variation in the drug uptake. If we give the same drug, sometimes we can demonstrate that even in different patients, the penetration is different in the brain. Different lesions have less or more amount of the drug penetrating there. The tumor type, so we don't want to treat breast cancer the same as lung cancer. It's not the same. The cells are different. It's a different tumor. We need a different treatment. And then different types of drugs also penetrate differently in different lesions. Also, more recently, we have been seeing that metastases in the brain are frequently different than the primary tumor, meaning someone who had a breast tumor that then became metastatic. And when you look, if you're able to get biopsies and look into that, it's been demonstrated that the metastases, the cells that constitute the tumors either in the primary lesion of the brain or in, let's say, a liver metastasis or a lung metastasis, they have different characteristics sometimes than the ones that are causing the brain metastasis, either because of genetic mutations or even molecular subtypes, meaning sometimes you have a HER2 positive breast cancer. When you look at the brain metastasis, is really not a HER2, or more frequently the opposite. You have a tumor that was not HER2 positive. If you are able to look at the metastasis tissue, you can see that it sometimes became a HER2 positive. So there's a lot of challenges there. And this has been described in preclinical work as well. The other issue is something that was until recent was very common, that is patients with brain metastases have been excluded from most clinical trials. So we don't know how they behave. I'm talking about systemic disease here, right? Systemic treatments. There was this publication from 2017 where they reviewed all the PubMed publications. And the PubMed, I don't know if everyone is aware, but is the site where we can find all the recent publications about whatever in medicine that we want. And usually is the place where we look for recent papers and so on. So they looked at that and they tried to look at, I think it was 2015 where they did that. And they found about 1,500 publications on metastatic breast cancer trials. I think they did 10 or 20 years, something like that, back. So what they found initially from this 1,500, about 39 were about brain metastases. And so they excluded those because the goal was to see how many trials will have any kind of eligibility criteria for brain metastases. So from this 1,500, almost 1,500 publications or new trials, what they found is that CNS or metastasis to central nervous system or brain was allowed in about 20% of those. In the, about 30% of those, it was not allowed. It was clear. We don't accept, we didn't look at the brain metastases. And about 52%, they didn't even mention that. It was something that was like not even considered. So this is a big problem because it's frequent that we don't have exact data about how different medications work or different treatments work for brain metastases or would do with that. So that's a problem, and it started to be changing with the HER2CLIMB trial. Why? Because we had tucatinib that had some signs of penetrating the blood-brain barrier better. So what people did was think better and allow the enrollment of patients with brain metastases in this trial. So this was a game changer in that sense, like changing the idea that we really need to enroll patients with brain metastases in systemic treatment trials so we can understand how that works for them and not think that will be a risk for the trial to failure and then not having them evaluated. So if you see the HER2CLIMB, what they did is the goal of the trial is really to evaluate a new treatment with tucatinib added to the trastuzumab and capecitabine for evaluating that treatment in metastatic breast cancer patients. But what they did is they allowed a lot of patients with brain metastases in different situations, because if you look there, you can see that you could have brain metastases that were already treated by radiation and then started the trial, brain metastases that were treated and were progressing and then entered the trial, or brain metastases that were treated by radiation but were not progressing, so were pretty stable, as well as patients that didn't have any treatment. They had new brain metastases but didn't receive any treatment. And that depended on the size of the lesion, where the lesion was. It was kind of a medical decision, and also the patient being accepting not receiving radiation for starters. So it's a very variable group. And this evaluation was done on how this worked for these patients as what we call subgroup analysis. And maybe you heard a lot about that, but what it means is that was not the main goal of the trial. The trial was not constructed for that. The goal of the trial is to evaluate patients with metastatic breast cancer and see how much tucatinib will improve their treatment and their life. Also, they had power to evaluate how much that will impact the progression-free survival of brain metastatic patients. But then, of course, we had a lot of patients treated with brain metastases. So let's look how that behaved for them. But those are more data to bring new trials on. So I think this trial proved really that brain metastasis patients need and can be included in clinical trials. And now we have to look at those results, especially the last part that was presented virtually at ASCO, looking for the specific effect in the brain metastases, because this can be an option for patients. However, we need to consider carefully how and where to use it. This also brought the idea of evaluate and design new treatments options for these patients, and also show that patients that the earlier potentially that you receive the treatments, the better responses you may have also in the brain. So the idea of prevention comes up again. And I know there's a big problem with prevention because people think, well, I have brain metastasis now, I cannot prevent it anymore. It's there, I want something to be done. So what I'm talking here is prevention. And Dr. Tsien touched a little bit upon that, that is, sometimes what you do is you treat that with radiation, and then you have medications that can prevent new lesions from coming up. So those are concepts that we have to start thinking about. This is just trying to inform you. I looked up what we have recently in terms of just this week, what are the trials available at the clinicaltrials.gov, and I'm not sure you probably know about this site where you can look up trials. And I looked up for brain metastases and HER2 positive breast cancer, and whatever trials had available or allowing patients with brain metastases. Most of them were actually developed for treatment of brain metastases, but some of them were for systemic disease, allowing a lot of brain metastases because they will evaluate cohorts of patients with brain metastases. I don't think this is a big number. I found 11 trials, and I know there are more under development and there are some closed because they are under evaluation, but this is what we have open as of now. And you can see that the three first ones that I mentioned, and I try to classify whatever type of things that we are thinking about treatment, and specific agents will be anti-HER2 that we already know about, neratinib and pyrotinib, and this is GDC, that is an agent that is more targeting the PI3K mutations that sometimes we talk about. Then because of the results of tucatinib and what we've been previewing that will be effective, a lot of trials, most of the trials now are around tucatinib combining to some or other agent to understand how to work that for patients that are HER2 positive, but also hormone receptor positive or not. There is a trial for leptomeningeal disease in brain metastases with tucatinib, which is also a very important thing. Leptomeningeal disease is the one that you don't have lesions measurable in the brain, but you have more in the revesting membranes of the brain, the leptomeninges. That's where you have disease, and the treatment and behavior of this is very different, and that's an area that needs much more study, but there is this study with tucatinib potentially used for that. Then we have, as I mentioned before, the tumors, the brain metastases seem to change a little bit sometimes. The characteristics, the genetic characteristics, the mutations that they can be targeted. And there is this one trial that is trying to look into that. This is not specific for breast cancer, but there is a group for breast cancer in the trial. So this is something to consider. And then there's the trial from secondary prevention that I'm gonna talk a little more because this is my trial. And Dr. Tsien also helped in the development of the beginning of this trial. So she knows a lot about that. And then immunotherapy, that is the new thing. And there's also trials trying to evaluate that for HER2 with atezolizumab and high dose trastuzumab. That is one option. If trastuzumab doesn't penetrate so well, then the doses that we use, maybe we should use higher doses, and there's some preclinical data on that. And then immunotherapy with HER2 CAR T cells, which are those cells, the T cells, the immuno cells that are modified to offer direct therapy for HER2 positive brain metastases. There are 2 studies on that one. So that's what is open now. There is this study that Dr. Tsien mentioned that I think it's gonna open at some point about preventing brain metastases with the tucatinib as well. And then for triple negative, as I said, the picture is a little worse because we don't have good options even systemically. For brain metastases in triple negative, we are still much behind, and there are 2 trials trying to use either the stereotactic radiation, but combining some immunotherapy for these patients, as we found that systemically immunotherapy can be effective in a group of the triple negatives. So this is what we have now open according to what I found in the clinicaltrials.gov. Now, let me talk a little bit about our trial, because I think this preventive thing is something that needs to be clarified a little bit. And our trial is actually the one that we have open is the HER2 positive breast cancer, patients that have up to 10 brain metastases and received some radiation for the initial treatment of this brain metastasis, either with stereotactic radiation or whole brain. We needed to combine, again, there was a question I saw before about, and in some place, I think one frequent question is about that. How do you combine the treatment of systemic disease? You have still metastases or tumor cells circulating in your body, and then you have the brain, which is the local therapy and needs perhaps a different approach. So we need to think both when we do that. And what we did in this trial was to use the TDM1 as the systemic treatment, and then adding the temozolomide, because temozolomide is a drug that has been known to penetrate almost perfectly the brain. It's used in in primary tumors of the brain, and it's known not to work very well for breast cancer. So we needed something to attack the breast cancer systemically, but there was evidence from the preclinical work or laboratory work from Dr. Stig, as I mentioned before, in the NIH, showing that this had a very good effect in preventing new brain metastases. So what we did here was combine both in a phase 1 to be sure that it's safe. We are having a very good effect in these patients. We still need 2 patients for the phase 1 to be completed. And then the goal is to go for the phase 2, where these patients will be randomized between T-DM1 alone and T-DM1 and temozolomide. So the main goal is that at 1 year, we can see that we decrease the chances of these patients developing new brain metastases. Just to give you some eligibility here, as I said, we need 12 patients for the phase 1 and we need 2 more. 10 patients are already in trial. These patients can have HER2 positive brain metastases treated between 12 weeks because, you know, one thing is an old brain metastasis that is there not doing anything and probably stable and maybe cured. Other thing is something that developed recently and potentially will develop new brain metastases. These patients for the phase 1 can have received either stereotactic radiation or whole brain radiation. After that, we're going to open the phase 2, which probably will be in more centers. And for that one is 1 to 10 brain metastases treated again between 12 weeks with a local therapy with stereotactic radiation or resection. And that's it for this one. Leptomeningeal disease, unfortunately, is not the target here yet. And then I just want to mention that for the next probably 2021, we're going to do the same or a similar trial for triple negative, which I think will be very important. Temozolomide combined to local therapy, and that local therapy could be lots of different chemotherapeutic agents that we know that are working for triple negative. And the goal is to keep the temozolomide for preventing new lesions in the brain, but transition between new systemic drugs as these patients may need, because triple negative systemic disease sometimes progresses faster than we see with HER2, for example. So this is a new trial plan for 2021. I just want to put that in your heads. So thank you for this opportunity, and I'm sure there's a lot of questions and specific doubts that you may have.
Thank you, Dr. Zimmer. So I'm going to actually go now to some of the questions that we have. The first one we have is, I have been told if you are estrogen positive and progesterone positive, but HER2 negative, you are at a very low risk or should not get brain mets.
I think I can address that. This is what I mentioned in the first slide, that I saw this question before. What we've been seeing is that we don't have a good number and good big evaluations of that, but that's kind of true. The numbers that we have so far is that about 7% of the hormone receptor positive, and sometimes 14, there's very small data, but it's less frequent that they develop brain metastases than the HER2 positive disease and the triple negative.
One of the questions we have, do you recommend brain imaging upon initial diagnosis of MBC if there are no symptoms?
The guidelines recommendations, you know, there are guidelines that we try to understand how to do with HER2 positive and triple negative disease. Both diseases, as we mentioned, are very frequent. Patients with develop brain metastases more frequently in those subtypes. And what's recommended is that it's not yet recommended before, you know, as a staging thing from the beginning, but it should be very low threshold to do that. Meaning, if you have any concern that you think about that because of some symptom or because of how much disease the patient presents or something, you should look it up. As I said, the word I think is low threshold to do it. I don't know if Dr. Tsien has something to add.
No, I just, again, at presentation, it probably is roughly less than 10%. And so again, screening every asymptomatic patient may not be helpful. In fact, you may kind of find things that you don't know how to address. So the low threshold makes a lot of sense.
Okay, so we'll go to another question here. Let me see here. Is it hard to tell if you have slight impacts to cognition? Is there a way to have a baseline where we at? Have a baseline cognitive test so that we can monitor potential issues if you have a history of MBC or brain mets.
I think that that's a really important point. And in fact, the trials that we are all designing, we really have never had a cohort of women receiving radiosurgery in breast cancer with neurocognitive data. So that is really, a strength of participating in a clinical trial, meaning there is strength in numbers, and having a well-studied cohort of patients is really going to help us to develop better therapies. And so in the past, a lot of this is kind of retrospective. And so being able to study patients in a prospective fashion is probably one of the most important things that we can do. So I agree.
Are there any triple negative immune therapies that will cross the blood-brain barrier?
So for the triple negative, for the one question that is very important is that the immunotherapies that we are seeing, the way that they seem to be effective in the brain is more not so much because they penetrate the brain, but because of the effect that they have in the system. In your system, your immune system is reinforced or stimulated by that therapy, and then it seems that in that way it gets there. It's not the therapy itself that needs to get there, but your immune cells stimulated by that systemic therapy that seem to be potentially get there and do some work. So that's the evidence that we have so far.
Again, I think that is really key, is that for leptomeningeal or triple negative, that immunotherapy actually can have a response in CNS disease. So that's kind of a new therapy that may be effective.
Okay. All right, let me go to this one here. We need more work on ER and triple negative breast cancer. Are there preclinical models of ER plus brain cancer, brain mets?
I think I'm not so sure. I would say I'm not so sure at this point. It may be, but I'm not very sure, because this is not, given the fact that we have most brain metastases in HER2 and triple negative, that's why people are, have been developing and try to develop models on that one. One thing that I have to say that is, and I think that's something that we've been thinking about as systemic therapy improves and patients live more, we will see more development of brain metastases. So that may become some issue in the ER positive area, and potentially it will be an area that will develop more models, preclinical models. But I'm not quite sure how the area is now. I don't know if Dr. Tsien has.
Yeah, Dr. Stieg actually has one model that is an ER positive. So yes, so each subtype actually, it really, the presentation, how it develops, and actually how the lesions look are actually quite different. It is very important. Each subtype really can drive the treatment. Okay. We can't put all breast cancer together. They won't behave the same way.
Nani, I have a question, and while I'm asking, then you can look for the next one. So one question that we have, maybe we'll start with you, Dr. Tsien, is how can someone tell the difference between dizziness and balance issues that might be coming from medication versus a brain lesion?
So again, I think the question really is that most of the time we will all have headaches that will not be related at all to brain mets. And I think that's a really important point, right? We can have migraines, we can have other symptoms that are simply not. And so the difference is really, these are symptoms that don't go away. These are symptoms that kind of continue to progress, or you might take medications, and there really is no other cause for that. And I think that's the key thing. If it's due to medications or other reasons, it's not due to the brain. And so that's where having a good oncologist and family physician, it's not just the symptom, but it's the evaluation that will really be key. So it's the team. The team is really going to be very important here.
Let's see, this one here. What does the cancer itself alter the BBB such that molecules, drugs that we wouldn't normally think could enter the brain may actually enter and be effective?
Yeah, that's been demonstrated in some cases, because as I was saying, that's this thing that people are calling now the blood tumor barrier, which means the tumor cells have, that barrier between the blood vessel that will bring drugs and the tumor that is sitting there as a metastasis seems to be different than the constitution of cells, and the way they communicate seems to have some differences. That's been well demonstrated now, and we are learning more and more about that. Yeah, you're right.
We actually have MRI imaging that can show that permeability. And we show that brain metastases at a certain size will lead to leakiness and increased vascular permeability that can allow drugs to cross. And actually radiation, these stereotactic treatments that I showed, and whole brain radiation, they also alter that blood tumor barrier. So once you have received those treatments, there actually is a potential, what we call a window of opportunity, where you, being able to combine the two can allow drugs that you wouldn't expect to enter. And we've, that's why some of those clinical trials are using that novel kind of combination to allow those kind of, whether it's immunotherapy or other things, to have more leakiness, more ability to penetrate.
And then I have one here, it's kind of long. Let me see if I can get to it. It says, the disparity in the quality of healthcare within the breast cancer brain mets community are even more significant among African-American patients. African-American feel they're not being offered some of the same treatment plans like other race. So trusting the oncologist, the palliative care physician, the nurse navigator, and a lecturer is a huge problem. What changes can physicians provide to the African-American community so trusting is not a huge factor?
I feel that, and we've been looking into that. Actually, not in brain metastasis, but in breast cancer, I looked into that, because I work at the Walter Reed as well. And so we got into data that because the idea is that the treatment is the same for everybody there, and why the results will be different. We didn't find much of a difference, but I can see that I've seen the behavior of the patients that this thing of trust and is there. The way I try to look at or to work with that is try to be very clear on the options that are available, not only, even if we don't have all available at that moment in that place, it needs to be known, because people, without knowing, you cannot look for options, even if I can't look for you, but if you can go to another place and so on. So I think the options have to be discussed as they are available, and the choices have to be exposed to the patients, what we can do here. And then the decision has to be done by both of them, and always trying to explain all the options. Now, I let Dr. Tsien say what her thoughts on that, but I would like actually, if you, especially talking to this group, one question I have: what the patients, what I don't know who make the question, but what would be recommendations? And maybe you guys from the panel or whoever is participating have heard a lot about that. What would be the because it's hard for the doctor to say how will I change it, but what do you think will be what are suggestions for what should be changed, you know, in terms of the doctor relationship? I'm interested in hearing about that.
Well, I will say this, because I know we have to wrap up, but I will say that as a patient, you know, one of my things is trusting my doctor as far as like, I know at one point I was having symptoms, and when I would mention that I was having a symptom, my physician at that time didn't take me seriously. So after telling her about the symptoms, and then after asking just to be on the safe side to get the MG done, the MRI, I'm thinking my work, to get the MRI done, I'm going to find out, you know, I was diagnosed with brain mets. So trusting your physician, having a relationship with them is for starters, because if you don't trust the fact that they care enough to have, to get an MRI done, if you have a symptom, or if they care enough to actually listen to, because we're our best advocate, you know, we know our bodies, we experts on ourselves. So it's all about really, your physician care enough to have you to get whatever done that you pretty much asked to have done. That would be one of my suggestions. That's just because of the fact being on the side of the patient. But we are going to have to wrap up. There were some great questions, and I really appreciate Dr. Tsien, Dr. Zimmer. Thank you again for joining us, and we'll see you later.